Hopkins University, where he is a professor of medicine at Epi in the Division of Endocrinology, Diabetes, and Metabolism. And he works closely with patients and providers as a consultant within the Johns Hopkins HIV clinic. And he is a graduate of Columbia and Hopkins as well, and also a Georgetown alum. He is an active researcher in the area of metabolic and endocrine disorders in people with HIV and bone disorders, and that's what he's going to be really speaking to us about today: osteoporosis in people with HIV and optimal evaluation and management to prevent fractures, which is a very timely topic as we think about our aging population and with HIV and how to really best care for them. So thank you so much, Dr. Brown.
Great. Well, thanks so much, Felicia, for the introduction, and thanks for the invitation to come speak to you today. So yes, I'll be talking about bones today. There we go. Here are my disclosures. Just to put it in context a little bit, we know that the population of people with HIV is aging. And so this is a great study, old now, looking at the projection of the population with HIV in the Netherlands. And of course, in the Netherlands, they have great data regarding all citizens of the country and can really do these studies very nicely. So back in 2010, you'll see that 30% of the population, so in those top 3 strata, were 50 and older, and the projection out to 2030, which is coming pretty quickly now, is that 70% of the Dutch HIV population is going to be 50 and older. And particularly notable is that yellow band up top, where that's the group of people 70 and older. And that group is going to grow to 10%. And we see this actually around the world. And of course, this is because of good antiretroviral therapy that we have available. These are data that were presented a couple of years ago at CROI, looking at the NA Accord population. And so you can see that with this increase in age, there's an increase in comorbidities. And so this is divided up into various age strata, and you can see that the people who have 2 or more comorbidities are in red, and that population with comorbidities is really increasing quite rapidly, particularly in the people 60 and older. And when you look at these comorbidities, again, this is from a Dutch study, the Age HIV study, that the prevalence of many comorbidities is higher in people with HIV compared to people without HIV. And you can see all these comorbidities here. And so it makes it complicated for HIV providers, particularly those who provide primary care, to try to figure out, okay, how do I prioritize this? How do I figure out which of these diseases is most important? What can we do about them for screening and treatment? And so I'm going to make a pitch to you, among all the things that you need to worry about as a clinician, why worry about osteoporosis? And so the osteoporosis is very common in older populations and more common in people with HIV compared to people without HIV. Osteoporotic fractures are a major source of morbidity and mortality. So we know about the morbidity and the loss of quality of life that a fracture, particularly like a hip fracture, can cause, but there also is an increased mortality. Osteoporosis is a silent disease until the endpoint of osteoporosis occurs, that is a fracture. And the important thing is that we can detect osteoporosis in a preclinical stage, that is before a fracture occurs, and we can actually do stuff to prevent those fractures. So here's data from the general population looking at the incidence of fracture over time in women and men. And you can see that after about age 65 in women, after about age 70 in men, the risk of fracture increases, quite dramatically. And there are lots of fractures that occur. And if you look at annual occurrences, fractures occur more frequently than other things that obviously are important health events, like strokes and heart attacks and breast cancer. And a driver of this increased fracture risk, of course, is bone mineral density. So our bone mineral density accrues quite rapidly during growth, and we reach our peak somewhere in our mid-20s or so. We stay pretty flat for a while, and then after about age 35 or 40, we get decreases in bone mineral density. And of course, it's relatively steady among men. In women, it accelerates with the estrogen deficiency of menopause. And one important thing, and this is particularly important for our pediatric population with HIV, is this attainment of peak bone mass. And so your bone mass at age 25 is very predictive of your bone mass later on. And so failure to reach peak bone mass is a major risk factor for fractures later on in life. And we know from various studies that children with HIV, as they get older, do not reach their peak bone mass. And so this is a separate issue that I won't be covering too much, but obviously a very important one. And I alluded to this about the mortality question, but I think it's quite interesting and probably not as recognized as it should be, is that the mortality does increase after fragility fractures, particularly hip fractures. These are data from a meta-analysis looking at women, and actually in men, the data even look even worse, that you have an increased risk of mortality compared to similar people who don't fracture, particularly in the first 12 months, and these might be related to particular complications related to the fracture. But even after 10 years, that increased risk of mortality does not go back down to baseline. And so this is, so perhaps by preventing these fractures, we could potentially not have this increased risk of mortality. I tend to think of these comorbidities and their events as in the overall process of aging and sort of what it means for aging. And I just want to show this one cartoon of a lifespan. So you have age on the x-axis, and then some measure of quality of life or physical and cognitive function on the y-axis. And so similar to what we see with BMD, things are relatively stable until they start to decline somewhere in the ages of 50, 60, 70, for example. But when you see curves like this, they tend to be smooth, but often they're not. Often they're sort of precipitated by specific events. So if you look at this person, pretty good until age 50, and then something happens to them, they have a heart attack, they don't recover, they have a hit in their quality of life and physical and cognitive function. Something else happens, like a bad pneumonia, again, a decrease, a hip fracture, a big decrease, a stroke. And you can see that as people have these events, it may become more difficult to recover from them, and that has a major impact on physical function and likely cognitive function and quality of life as well. So if one of the important things that is, if we can prevent these events from happening, perhaps we can bend that function curve upwards so that people, not only to perhaps increase lifespan, but to increase health span as well. And this is sort of the pitch for trying to prevent fractures so that you don't have one of these events that precipitates this decline. So let's take a look at fractures and osteoporosis in people with HIV. So these are some early data in the Mass General Partners Healthcare System, looking at the fracture risk in people with and without HIV, women on the left, men on the right. And what you see is that after about age 40 in women, after about age 30 in men, you see an increased rate of fracture in the people with HIV compared to the people without HIV. And that, importantly, the difference between those with and without HIV increases with increased age. And so it's really important as we think about our older patients. And if we look at the prevalence of osteoporosis, which is one of the big drivers of this decreased risk, we see that the prevalence in people with HIV is really quite high. This was a meta-analysis that we did, oh my gosh, almost 20 years ago, but the results have held pretty constant over that time. The overall prevalence in these 11 studies was about 15%, and compared to their respective control groups without HIV, it was over a threefold increase in prevalence. And so obviously this is a really important factor when we think about fracture risk. So let's take a step back a little bit and think about what we mean when we say osteoporosis. And so this is a definition that's been around for a while, but actually quite a good one. So osteoporosis is defined as two things. One is low bone mass, and the other is microarchitectural deterioration of bone tissue. And that second part of it, which is a bit of a mouthful, is otherwise known as bone quality. So aspects of bone that aren't taken into account by measuring bone mass. And then the last part of the statement is, what the consequence is, which is fracture. So if we look at these micrographs of bone, what you see, the bone on the left, and this is a vertebral body, this trabecular bone, you can see that you have nice spaces, good organization of the bone. There's quite a bit of bone there. And that's normal. And so, but the osteoporotic bone, not only is there less bone there, but the bone is not as well organized. And you can see these trabeculae are thinner, and you can imagine more likely to fracture. When we think about these operational definitions, we use measures from dual energy X-ray absorptiometry, and we define them based on the T-score. And the T-score is relative to the mean, the number of standard deviations away from the mean of someone at their peak bone mass. And so osteoporosis is a T-score less than or equal to minus 2.5. So 2.5 standard deviations less than someone at their peak bone mass. Normal is a T-score that's greater than -1, and osteopenia is sort of in between at -1 to -2.4. The important thing is that there is this relationship between bone mineral density as measured by DEXA and fracture risk, but it's not a clear one-to-one correlation. And so it gives you an idea of how fragile the bones are, but doesn't give you all the information that you need about the bone. So this is really measuring bone mass and not that bone quality issue that we talked about before. A couple other things to think about. One, and this is under the caveats here, I'll do the second one first, and it's because it doesn't measure everything about fracture risk. It only explains about 50% of fracture risk. So things like fall risk, things like the bone quality aren't picked up in BMD. And the other thing to think about is these are cut points that were developed in postmenopausal women and in older men. And so we should be using Z-scores and in men less than 50 and in premenopausal women. And here the Z-score, the reference population, is an age-matched population. And so it's really a low bone mineral density for a given age is the interpretation of a Z-score. And we tend to think that 2 standard deviations below an age-matched person is considered low bone mineral density. So for those of you who haven't seen a DEXA scanner, this is sort of what it looks like. So the typical sites that are measured are the spine, and that's what this patient is doing. Her legs are up on a block, and you're measuring between L1 and L4. With that view, it takes all of about 10 seconds to do a spine. The hip, what will happen is they'll take the block from underneath her knees. She'll put her legs down, and there'll be a little bit of a brace to separate them, make sure that the leg doesn't move. And with that, it measures the hip, that is the total hip, and also the part of the hip that's most vulnerable to fracture, the femoral neck. In some cases, you can do a forearm measurement, and this would be in cases where for say, because there's surgical hardware in there, you don't get a good spine or hip measurement, or in specific cases like with primary hyperparathyroidism, where the forearm bone is most affected. This is where it's important to do a separate forearm scan. So bone is separated into cortical bone and trabecular bone. The trabecular bone are the bone that I showed you with the micrograph before, it's sort of where the marrow is, this sort of network of bone, and then the cortical bone is the bone that surrounds it. And you can see that this is in this cartoon here, that this is a hip bone. The hip's about 50-50 cortical bone and trabecular bone. And you can see the difference between normal bone on the left, osteoporotic bone on the right. So an osteoporotic bone, you get thinner cortices and fewer and thinner trabeculae. So it should be mentioned that the sites have different proportions of trabecular and cortical bone. So the lumbar spine is about 80% trabecular and about 20% cortical. The hip is about 50-50, and the forearm is about 80-20 leaning towards cortical bone. And different processes affect cortical bone and trabecular bone differently. Say, for example, corticosteroids have a major and very fast effect on trabecular bone. So this is, when you order a DEXA, this is the report that you get back. This is the image, and the image is really just for placement, and it measures L1 through L4 for the spine, and you have an area of the bone, bone mineral content, and you can calculate the bone mineral density from that. And then here's the T-score and the Z-score based on different reference populations. It's useful to look to see what the reference population is. And so for T-scores, no matter what the sex or race is of your patient, by convention, the reference population is white female. Whereas for the Z-score, it's matched to the patient's race and gender. And here you can see the results on the hip. And we really only look at this femoral neck, this neck part, and then what's folded here is total. We don't really look to see the trochanter and the intertrochanteric area or the Ward's triangle, since they're very variable. So those are the two values that we really look at. So an important thing to know about fractures and bone mineral density, and this sort of gets at this question about how much does low BMD predict fracture risk, is actually most fractures occur in people without osteoporosis. And so there's a lot going on in this figure, so I'll walk you through it. So here you have the BMD T-scores on the x-axis and the number of fractures on the y-axis. And what you see is that in these clear bars the white bars, that as BMD decreases, so does the risk of fracture, which makes sense. And then you look to see what the number of people with fractures are. And because there are so many more, and this is in the black bars, and what you see is because there are so many more people in this osteopenia range, there's actually more people, more women in this case, who are in the osteopenia range who have fractures. And so herein lies the problem with DEXA. It's a good measurement, but not a great measurement. And so it helps us guide management, but doesn't tell us everything we want to know about fracture risk. So let's switch gears a little bit and talk about bone loss in people with HIV. And like all metabolic complications or complications in people with HIV, it's a complicated mix between host factors. And you see some of these factors here that are more common in people with HIV that contribute to bone loss. You have effects of antiretroviral therapy, particularly TDF, but also protease inhibitors. And then you have effects of the virus, and we know that immune activation that we see even treated with people with HIV has impact on both osteoblasts and osteoclasts. So it's a complicated mixture of all these factors that contribute to bone loss. One thing that's clear from pretty much all the literature is that after antiretroviral initiation, particularly in the first 6 months, there is a rapid increase in bone turnover, which favors bone resorption. And it doesn't really come back to baseline afterwards. And so this is a study that Grace McComsey led, ACTG study, in which people were randomized to one of 4 regimens, so the nuke backbone with TDF-FTC or abacavir, and the third drug was efavirenz or boosted atazanavir. And this first graph shows you the difference between TDF and abacavir. So with greater bone loss in those who are randomized to TDF. And what you see on the other side is differences between efavirenz and atazanavir, where those who are randomized to atazanavir had a greater degree of bone loss. But what I wanted to really show you here is that bone loss happened regardless of the regimen that people were randomized to. And as was suggested from that study, and has been seen in many other studies that compare TDF to other regimens, TDF is associated with more bone loss. And PIs, as I had mentioned before, are also associated with more bone loss related to efavirenz, as you saw in that ACTG study, and also related with respect to PIs. And so this is a study we did in the ACTG, where we randomized people to one of two PIs, boosted atazanavir, boosted darunavir, or raltegravir. All of them got TDF-FTC. And you can see there wasn't a difference in BMD between the PI arms, but when you looked at the PI arms versus raltegravir, this is where you saw the differences. Now, what happens if you start antiretroviral therapy without a TDF or without PIs? And it turns out, and this is a Gilead study, that lo and behold, there is a decrease in BMD here, about 1% or so, maybe between 0.5. So much less bone mineral density loss, but still bone density loss nonetheless. And the other important thing is that, and this is the challenge of interpreting averages, is that some people lose a significant amount of bone, and there's heterogeneity, of course, between different people and how much bone they lose with antiretroviral initiation. We also know that when we switch off these medications, when we switch off TDF or ritonavir boosted PIs, you do get an increase in bone mineral density. So this is potentially an important strategy, and TDF in our settings in the US isn't used very often, but it's an important, potentially an important strategy in many places around the world that are still using TDF. So how can we prevent fractures in people with HIV? So the first thing, and the first part of the talk was about ART switching. So we should be avoiding TDF and PIs, particularly in individuals at higher fracture risk. The next thing we should be doing is screening. So I had mentioned that this osteoporosis is a silent disease, and so we should be trying to screen for cases of osteoporosis before a fracture happens. And so the recommendation is to screen all men with HIV 50 and older and all postmenopausal women. And of course, the caveat that I mentioned before. These are the US guidelines in the general population. So screening those who are 50, who have a fragility fracture at age 50 and older, women greater than age 65, men greater than 70. And then if for younger postmenopausal women and men 50 to 69, to look at clinical risk factors of fracture. And one of the risk factors for fracture that is actually in the guidelines, which will support any claims that your 55-year-old male shouldn't get would support a claim that they should get a DEXA, is that HIV is one of these conditions where DEXA screening is warranted. So there are other modalities to assess fracture risk, and spine X-rays are actually a pretty good one, and can pick up occult spinal fractures. About a half or a little more of spine fractures are not clinically evident, and so they can be seen on just plain films of the spine. And this is an older study, but I think a really interesting one from Italy, where they took a population of people in the clinic, sort of all comers in a clinic, and did both DEXA and plain spine films. And they looked at people who had some fractures, so the SDI greater or equal to 2 versus those who do not. And so this is the spinal deformity index. And what you see is that there was a decent number of spinal fractures. So 15% had some spinal fractures. And what's interesting is that many of these fractures occurred in people who had either osteopenia or normal bone mineral density. And this sort of echoes what I showed you from the general population, that osteoporosis does tell you something about the bone, but maybe not everything you want to know about the bone. So I use the plain X-rays when I'm trying to decide, especially whether or not to put someone on treatment that's sort of borderline, or whether or not to take someone off of treatment whose bone mineral density is sort of in the borderline area. And I think this can be a really helpful and inexpensive tool. Another potential tool that you can use is the trabecular bone score, and this is something that is derived from the DEXA measurement. And so the DEXA machine that you use will have to have the software, but it's many DEXA machines have it. And it's basically just pressing a button to get the TBS. And so it takes the picture that I showed you and transforms it into what they call a variogram. And you can get a sense of the quality of the bone, the quality of the trabecular bone from the spine images, based on a computer read of the images. And so you can adjust the FRAX score, which I'll tell you in a second, based on this trabecular bone score, and it does add information to bone mineral density. And so I mentioned that with DEXA you're measuring bone mass. The other part that isn't measured well is bone quality, and this is an aspect of bone quality. So it does provide useful information. So once we do the screening, we have to think about, okay, well, which candidates are appropriate for treatment? And so here are the US guidelines in the general population regarding treatment. So those who have hip or vertebral fractures, those with osteoporosis at the femoral neck, total hip or spine. And if you're in this osteopenia category, you look at the FRAX model, which is a sort of the Framingham, what Framingham or the pooled cohort equation is to cardiovascular disease, FRAX is to fracture. And so if you have a risk of all osteoporotic fracture greater or equal to 20%, or hip fracture 3% or greater, then it warrants the patient to be put on to some specific therapy for their bones. And importantly, this really applies to postmenopausal women and men greater than 50. So here's the FRAX tool if you haven't used it. So basically what I do is just Google, whatever search engine you're looking at, put in FRAX, it comes up to this website. You pick your calculation tool and your country and your population, and you fill in these data, and you can see that the data that are needed here. You can do this with or without BMD, but it's more accurate, of course, with BMD. One caveat for applying this to people with HIV is that it tends to underestimate fracture risk in people with HIV. So there's a question whether or not we need to be doing anything different when people with HIV. Do we just up the fracture risk, whatever fracture risk you get? Do you put in a different age? Say fractures, we've shown in the MAX study, for example, that fractures occur about 10 years earlier in our men with HIV compared to those who do not. So this is an important consideration about how to use the FRAX tool, and gets at this issue of should the treatment thresholds be any different in people with HIV? So once you've decided on treatment, the next question is, well, what treatment should be given? So we got a lot of options potentially. There are some general recommendations. So getting about 1,200 milligrams of calcium, preferably from the diet. So I basically calculate someone's calcium intake from the various calculators that are available online, and then supplement the rest in calcium citrate, for example. Vitamin D supplementation is important in people with osteoporosis. I do measure their 25 vitamin D and try to keep it up above 20. Generally, that requires 1,000 or 2,000 international units of vitamin D a day. Sometimes you need to fill up the tank with high dose vitamin D and then do maintenance dose. Smoking has specific effects on bone, so yet another reason to have people stop smoking. Heavy alcohol use does also affect bone. Weight-bearing exercise is key, and there are other medications that may be associated with osteoporosis that, if it's possible, should be avoided. So when we think about the pharmacologic therapies for osteoporosis, you can divide them into osteoclast-directed therapies, that is anti-resorptive therapies, or osteoblast-directed therapies, or anabolic therapies. On the anti-resorptive side, we have bisphosphonates. We have selective estrogen receptor modulators like raloxifene. We have denosumab and hormone replacement therapy. On the anabolic side, we have teriparatide and abaloparatide, and our newest agent to treat osteoporosis is romosozumab. So I'll be briefly reviewing these. Bisphosphonates are generally considered first line. We have some data in people with HIV, mostly with alendronate and zoledronic acid. Zoledronic acid is given once a year. We don't have fracture data. These fracture trials are really quite big. What we do have is the bone mineral density data. But based on the bone mineral density changes that we've seen over the years in these various bisphosphonate studies in people with HIV, we wouldn't expect any different in terms of the effect on vertebral fractures, somewhere about 25 to 50% in people with HIV. One question, particularly when we had a lot of people on TDF, is whether it makes more sense to switch off of TDF or to do bisphosphonate. And this study, which was done in Australia, showed that the impact with bisphosphonate, here they used zoledronic acid, was higher than switching off of TDF, both at the spine and at the hip. So there's a question about whether to use oral or IV bisphosphonates. Oral alendronate, it's a lower cost. There can be associated GI problems, so alendronate can have some irritation to the stomach mucosa. The bioavailability is really low, so less than 10%, and so the absorption is bad. This is why we need people to take alendronate on an empty stomach. And also, it tends to drop off people's radar. So it's alendronate given weekly, and the compliance and persistence with alendronate therapy is really quite poor. And so this is one thing that you have to keep in mind as you think about potentially using alendronate, is whether in 6 or 12 months the patient's actually going to be taking it. And so it's important when doing your medication reconciliation to really ask about the alendronate. The advantage, of course, of IV is that basically it's a directly observed therapy. The person comes into clinic once a year and gets their zoledronic acid. One of the problems was an acute phase reaction, sort of like a flu-like syndrome, generally with the first dose. So it's about 20 to 30% with the first dose. It goes down to 5% in the second dose and 1% in the third dose. But for those who experience it, it can be unpleasant. You can decrease the chances by pre-medicating with either ibuprofen or acetaminophen. It can lead to hypocalcemia, which is another potential problem with it. One of the rare problems, but a problem nonetheless, are long-term adverse events. And so these are generally seen with prolonged exposure to these drugs. So osteonecrosis of the jaw and atypical femoral fracture. So osteonecrosis of the jaw is the death of the jawbone. These atypical femoral fractures happen. You can see this cortical thickening here of the bone and sort of what they call a chalk stick fracture here, and generally mid-shaft. So I mentioned that most fractures happen to people either through the trochanter, this bump here, or if you look at the image on the right, or through the femoral neck. And here you're seeing mid-shaft fractures, and this little bump here can herald a fracture or that will be coming. So these are problems, there's no question, but rare problems. And so it has the recognition of these problems has tempered the use of these quite a bit. And you can see this when you look at the declining use of bisphosphonates. You can see that there was really a peak somewhere around 2006, and it's this latter part of the 2000s that these problems began to be recognized. And you can see a big drop off afterwards, after that time period. And there's concern, from the patient side, on the provider side. And the net result is that there were people here back in the early 2000s that probably didn't need to be on bisphosphonates, that were put on sort of overzealously. But what's happened is that we have a lot of people who would benefit from bisphosphonates, where the risk benefit really is in favor of using them, but people aren't using them because of these rare side effects. One of another result of this recognition of these long-term consequences are potentially limiting exposure, and in those people who get down out of the osteoporotic range, and if they don't fracture, that giving a trial after 5 years of oral bisphosphonates or 3 years of zoledronic acid to think about a holiday. And so there's still a lot of questions about these holidays. How long do you give the holidays? How do you monitor? What medications, if it looks like the person should go on, if they have a drop in bone mineral density, for example. Personally, I monitor with bone mineral density. I do yearly DEXA. Some people use bone turnover markers. So, the bisphosphonates decrease markedly bone turnover markers. So when bone turnover markers begin to rise, they're dosed then. I think that I tend to use the DEXAs, and then think about whether or not to go back on bisphosphonates or some other medication afterwards. This was a study from a few years ago looking at a large clinical database, the Kaiser Permanente database, just to put in perspective the risk of these atypical femoral fractures compared to the hip fractures prevented. And so here you can see for white women, and there's similar data for other racial groups, but you can see that overall there's about 38 fractures per 10,000 women, atypical femoral fractures. But about 1,300 fractures would be prevented, or 591 hip fractures. And so this really, there's a difference in magnitude here as to how the fracture prevention versus the risk of atypical femoral fractures. And the other important result from this paper was that the risk of atypical femoral fractures does decrease with increasing time since discontinuation, suggesting that the holidays do work in decreasing the risk of atypical femoral fractures. So bisphosphonates are anti-resorptive drugs, as is denosumab. So denosumab is a monoclonal antibody to rank ligand. So what's the rank ligand all about? So osteoblasts and osteoclasts are in constant communication, and one way they do this is through the OPG rank ligand system. And so the rank ligand, rank is on osteoblast precursors. And rank ligand is created by osteoblasts and bind onto osteoblasts. Blast precursors. This should be osteoclast, and to increased osteoclast activity. And so what this drug does, denosumab, is to bind onto rank ligand so it can't bind to rank, and so osteoclasts are not activated. And so this has a very profound effect on bone resorption by decreasing osteoclast activation, increasing BMD, and decrease fracture risk. There is some concern about infection. So in the pivotal trials for denosumab, one of the side effects, pretty rare actually, was skin infection, particularly erysipelas. And so since this rank ligand system is used by immune cells to communicate, there's concern that this may be a mediator here. It is used in people who are immunocompromised, say people who have transplant-associated osteoporosis, and used quite well there. I tend to avoid it in people with low CD4 cell counts, but I do use it in people who have CD4 cell counts that are above 500. So it's given by a sub-Q injection every 6 months. One of the things you have to know about with denosumab is that it's a very potent suppressor of bone turnover. And after that 6-month period, the bone turnover starts to increase and actually increases above baseline. And this is a period, say, the 6 to 12 months after the interval, after the dose has been given, where you can see an increased risk of vertebral fractures. And so it's really important for patients to be sure they're on this 6-month schedule. And then after the last dose, to follow with the bisphosphonate to suppress that bone activity so you don't get that rebound effect. Unlike bisphosphonates, which are approved really only down to a GFR of about 35, this can be, the denosumab can be given in those with low GFR. There is, however, concern for hypocalcemia in this setting, so we have to use these cautiously. On the other side of things, we have the anabolic treatments. And so this is either PTH or PTH-related protein analogs. And these are given as subcutaneous injections for daily, generally given between 18 and 24 months, and then you need to follow them with an anti-resorptive. This is a nice trial that was in the New England Journal some years ago, looking at the relationship in glucocorticoid-induced osteoporosis, the difference between alendronate, bisphosphonate, and teriparatide. And you see that the gains in bone mineral density you get are higher with teriparatide and alendronate. And so we tend to use anti-resorptives first, and if there's failure, go to teriparatide. But in patients who have severe osteoporosis, those with lots of fractures or have T-scores that are in the less than -3 range, this can be given as first-line therapy and then followed by an anti-resorptive. As I mentioned, the latest osteoporosis drug works by a different mechanism. It's considered an anabolic. And so what this is a monoclonal antibody to the hormone sclerostin. And so we have osteocytes that are rest in the bone matrix that are sort of control the osteoblasts. And the osteoclast. And one of the ways they control the osteoblast is to secrete sclerostin, which inhibits osteoblast activity. So it's decreasing this bone forming cell, the function of it. And so what the monoclonal antibody does is bind to sclerostin, so it's releasing the brakes on the osteoclast, so you increase osteoblast, so you increase osteoblast function. And so here's increases osteoblast activity. It also has a secondary effect of inhibiting osteoclast activity, so doing the things that you want. So it's given for a year with monthly injections. There have been studies which have looked at bone mineral densities changes versus alendronate and versus teriparatide, showing good changes. There's studies showing greater fracture risk reduction versus alendronate. Generally, it's for severe osteoporosis or intolerance to other meds. It hasn't been approved yet in men, which can be a problem. There is some concern about the cardiovascular effects of this drug. And so you'll see it when you look at the package insert. So you need to use with caution in people who have a recent cardiovascular event. So switching gears and talking about some non-skeletal fractures. So we know that it's risk for fracture. We know that falls are really important. There are lots of risk factors for falls, and I list some of them here, and many of them are more common in people with HIV. Then there are many strategies that can be taken to prevent falls. And one of the important things to do in clinic is to ask about fall risk. And this is a great question to start the discussion of if the person is worried about falling. It turns out that those people who are worried about falling are actually at increased risk. So these are people who are sort of changing their behavior because they're worried about staying on their feet. And this can open the discussion quite nicely in clinic. The importance of identifying people at increased risk of falling is that you can refer people to physical therapy for assessment and management of strength and balance. it's also important to think about some of the environmental factors that may be contributing to it. So things in their household which may increase the risk of falling in terms of low lighting or loose rugs or clutter or wires that people may trip on. And some behavioral assessment modification, avoiding excess alcohol and drugs. Some medications, particularly anticholinergic agents, may increase the risk of falls. Sturdy shoes and avoiding slippery and uneven surfaces. So I'll end by saying that fractures are likely to be a major source of morbidity and mortality for aging with people with HIV. In general, DEXA screening should be more aggressive in people with HIV compared to people without HIV. Bisphosphonates should be considered first-line therapy. Adherence is really a major challenge, and there are a lot of questions remain regarding the optimal duration and treatment and sequencing of the medication in people with HIV, but people without HIV as well. And fall prevention is really essential to prevent fractures. So I just want to end by thinking about this, about osteoporosis in the same way we think about HIV. So there's an HIV treatment cascade that we all know about, trying to identify people with HIV, getting them diagnosed, linked into care, retaining care, on antiretroviral therapy, and suppressing their viral load. And similarly, and this, I'm making these numbers up, is that we can identify people at high fracture risk, get them on specific treatment, and think about again trying to optimize adherence to that specific treatment so that we can decrease fracture risk and improve health span. And so here's what I showed you before. So if we can decrease all these things, including fracture risk, we can start to bend that curve upwards and have people age in a more healthy way. So I'll end there, and I'd be happy to take any questions.
Thank you so much, Dr. Brown, for that comprehensive, excellent talk. There is a question in the Q&A when you were referring to DEXA screening about insurance coverage and difficulties with Medicare. And given that we want to try to be more aggressive about screening, what are some strategies you have for trying to get this covered?
Yeah, I mean, I think it's pretty clear from the Bone Health and Osteoporosis Foundation that that men 50 and older and all postmenopausal women should be eligible for DEXA scans. So that's the recommendation. So that's what I would go to as evidence to cite that yes, my patient with HIV should be getting a DEXA scan, even though they're not 65 or older or 70 or older. The Bone Health and Osteoporosis Foundation recommends DEXA in this population because of the increased fracture risk. Sometimes it's an uphill climb, and it really depends on your location. And in Maryland, I don't have too big of a problem, but I know in other places there is an issue.
Yeah, it's often the diagnosis code is also one of the issues that comes up with Medicare patients.
Yeah.
There's a couple more questions. Do you have recommendations for people with HIV, osteoporosis, and CKD4, as most of the meds are renally cleared? They just want to know what would the next best step.
Yeah, so osteoporosis in CKD is tricky because some of the, what we've been talking about are most cases of osteoporosis is when there is an increase in bone turnover with bone resorption outstripping bone formation. There are some people with renal disease with osteoporosis where they have adynamic bone and low bone turnover. And so it can be really tricky to distinguish those, because one way that you might think about is, well, let's measure bone turnover markers to figure out, well, who has high bone turnover and who has low bone turnover. The problem, of course, is that these bone turnover markers are all cleared by the kidney. And so they don't give you an accurate depiction of what's going on. The gold standard way of determining, what if the person has high bone turnover or low bone turnover is a bone biopsy, which is sometimes difficult to get, but really has definitive treatment, give you a definitive answer. The other way, of course, is to just try a medication. Oftentimes it's denosumab because of you can use it at low GFRs. And I really, wouldn't necessarily. I'm a little more reluctant to treat in people with severe kidney disease unless there are fractures. And so that's the other. That's one of the important things that a person has, and the clinical consequence of it. The other important thing is to look to see what their mineral metabolism looks like, and whether or not severe hyperparathyroidism is part of their picture, and that might require specific treatment.
Great, thank you. There's another question about newly diagnosed osteoporosis in someone with HIV. In what situations would you begin therapy with an anabolic rather than an anti-resorptive?
Yeah, no, it's a great question. I think I would, the caveat here is that there's relatively little data regarding anabolics in people with HIV. There's no, I use them all the time, and so there's no reason they would work any differently. But having said that, I think that I would reserve it for people who have very low bone mass. So with T-scores that are less than -3, or who have fractures. So I would give them up front the either abaloparatide or teriparatide, give it for 2 years, and then switch them to an anti-resorptive.
All right. There's a question about follow-up DEXAs in people with HIV who have a non-osteoporotic DEXA score at age 65. How often, or would you at all get subsequent DEXA?
No, great question. Yeah, I think that it depends on where their bone mineral density is. So if they are they're not in the osteoporotic range, but they're say in the -2 to -2.5 range. I would probably get it in 2 or 3 years just to see. And then if if they have lesser degrees of osteopenia, maybe extend that to 4 or 5 years. People have totally normal bone mineral density. I think you could, depending on how old they are, you could do it in 5 to 10 years without a problem. And of course, as I mentioned before, the DEXA is only telling you part of the story. So if they have a fragility fracture, regardless of what their bone mineral density is, you may choose to treat, and know that the DEXA is not telling you everything.
Yeah, there's a question about bone-specific alk-phos, and that some specialists order this, and can you comment on its use?
Yeah, so bone-specific alk-phos is a bone formation marker. So it's increased in conditions of increased osteoblast activity. So in our typical Chem20s, we get alkaline phosphatase, which has multiple sources, and so the bone-specific is just that. So it can be helpful, when you have an alk-phos value, to fractionate and get a sense of where the alk-phos is coming from. So in situations of high bone turnover, you'll see a high bone-specific alk-phos, and even in situations of treatment. So with an anabolic agent, and this is totally normal, this is what the drug is doing, you'll see an increase in alk-phos and bone-specific alk-phos.
And one last question here about a patient who, with falls, who had osteopenia on prior DEXA and was on a bisphosphonate for 5 years, but completed over 10 years ago. Would you recommend another bisphosphonate or go for an alternative?
Yeah, so that's a good question. If they're in the osteoporotic region, I would I think you could do either. You could either do denosumab, or you could do another round of bisphosphonates. I might, depending on how old the person is, I might do denosumab, as the impact on fracture might be a little bit better, but it really depends on the situation. Either would be acceptable.
Thank you so much. There's one more question, it looks like, in the chat, that's about do all doctors use the trabecular bone score?
Yeah, no. So not all machines have the software, and I hope they do. If they do have it, they report it. So I know our machine at Hopkins, our clinical machine, it does have TBS, but you need to ask for it. So in the notes of the radiologist, you can just say include TBS.
All right. Thanks everyone for all those great questions. And thank you so much, Dr. Brown, for this really comprehensive, great talk on osteoporosis and HIV.
Great. Thanks for the invitation. Take care, everyone.
Bye.